Thanks, Chair. I'm aware that we are running out of time, so I will be quick. Chris, you have sat there silently and stoically for 2 hours, so perhaps I might direct a question towards yourself. Public health, population health, with all the changes that are going on, NHSE being abolished, ICBs being cut by 50%, HSA presumably continuing as it is. Population health, where does that sit in this landscape at the moment?
Well, I think it's two answers. The first one is within the department. That's obviously separate from, in large part, if I could divide population public health prevention into two bits. The primary prevention bit, which is the things that government does, both local and national, broadly, is not really going to be affected by the changes in terms of the bringing of the NHS, because that's always been a separate function.
Sorry, just by that you mean that the local authority functions will remain as they are with the DPHs sitting, and we'll come to devolution in a minute, maybe for Jim, but carry on.
Well, let me complete the answer and then I'll come back to that. Secondary prevention, which is what happens when a clinician sits in front of someone and says, look, here's a risk factor, can we reduce it? That may be affected in operational terms by bringing together of NHS and DHSC, but in practical terms it won't. I'll go back to a point that the Secretary of State has made repeatedly in different ways, but I'll repeat it as well. For every clinician on the front line, for almost all the technical people and for most of the policy people, their day job will not change from one day to the next as a result of these changes. Because what they're doing is they're working for patients, they're working for the public, and that's what they should be doing. They shouldn't be spending their time thinking about reorganisations. So
Understood, Chris. So if I can just perhaps direct your thinking to the Department of, known catchily as OHID, that is presumably obsolete now, or continues as is but will no longer be. Where does that health inequality mandate sit moving forward?
No, I don't think there's any reason to think that that's going to change, actually.
Okay.
And although PHE was abolished, OHID, which is really...
Yes, I think I said OHID had been abolished. It was the other way around.
No, right, yeah.
Excellent. Good to clarify.
Not setting any new hairs running.
Yeah, those functions are still very much present in the department. They are broadly divided into the group of things that are on the primary prevention I talked about, the secondary prevention facing the NHS, primary care, secondary care, and then research and data, which is off to one side. But the functions are still there and will still be needed.
Okay, excellent. And so do we foresee a world, not anticipating the 10-year strategy, where the functions of PHE, so HSA, the Health Security Agency, and OHID, and perhaps that sort of strategic level thinking, that we bring them more closely together again?
Well, I certainly think, and without in any sense prejudging the 10-year plan, the Secretary of State has made clear repeatedly that the shift from treatment to prevention is a key part of this, and he said in several of his answers today he wants to push things out further out to the periphery, but all of that can work with a public health system that's working. There will still need to be some central functions, which will include data and research, which is much more efficiently done centrally, and primary prevention, which really has to be done by government under democratic control.
Excellent, thank you, Chris. And perhaps to Jim then, devolution. So it's been mentioned several times in this session. As we're aware, concurrently, local authority is undergoing a process of devolution, and for those areas in the country that don't have devolution, by the end of this Parliament, they are mandated to undertake it. How is devolution in health working alongside devolution in local authority, and do you foresee sort of areas of synergy or areas of issue arising?
Yeah, so it's a really big part of what you do locally when you're running trusts or ICBs. You're trying to work really well with local primary care, local council, and increasingly combined authorities where they exist. So it's absolutely a big part of what we want people to be doing, getting really close, joining up public services wherever possible, and maximising the value for the public. And
in terms of resources and responsibilities, do you foresee a point where integrated care boards are working so closely with combined authorities that there is a level of accountability into those combined authorities, perhaps looking at some of the accountability that currently comes to central government?
I'd be thinking about from a structural governance sense, a lot of this has still got to be worked through, and I'd agree with what Secretary of State said earlier on about being careful not to just end up in a position where we're loading people into boards for the sake of it, issue representation. But the principle of being very aligned, very joined up in terms of strategic planning, impact for the population, would absolutely expect that. And some ICBs, coterminosity with combined authorities is a big thing for them in the discussions we've had over the last few weeks. I know there's less so where it's less developed.
I think there's different appetite from some of our mayors as well.
I think Andy Burnham recently put out some actually really interesting ideas and is doing some really interesting work, particularly in the prevention space, that I think we should look at. And I think one of the interesting things about Andy is that one of many interesting things about Andy is that he's sat in my chair before and is now driving population health and prevention work as a mayor, and I think that's really good and really interesting. And I suspect if given the chance, we would probably take on greater responsibility in this area. Oliver Coppard similarly doing a similar agenda and similar ambition. I'm not sure every mayor would have the same level of enthusiasm or appetite, but we're certainly up for trying things differently and testing and learning. And certainly, some of the public noises that Andy's made about different approaches he'd like to try in Greater Manchester, we'd be really open to trialling and testing different things and seeing
great.
What works.
Yeah, and I think that aligns with the white paper that came out around devolution, where it does say that the mayor, it will be expected that they'll be appointed to one or more relevant integrated care partnerships. So that aligns closely. So I suppose my final question, Secretary of State, is for yourself. We're often accused in politics of using health as a political football. In terms of the changes that are now being undertaken, how will you ensure that for future Secretaries of State, these are seen as positive, nothing is ever apolitical, but positive, sustainable changes that are not simply undone by your successor or future successors?
Well, no Parliament can bind its successor, but I thought it was really encouraging, actually, how many of my predecessors, Labour and Conservative, were, to different degrees, welcoming the changes we're making, some more cautiously than others, some emphasising different opportunities or risks to different degrees, but broadly speaking, we have achieved broad consensus on this, and I don't think that is a bad thing at all. And I know there are some people who, whenever someone from the other side says something positive, kind of says, "Oh, this is proof that you're not being Puritan enough or ideological enough." But I think as far as possible, especially when it comes to the overall system architecture, it is a good thing if people know that from one government to another, from one party to another, although there'll be different policies and different choices, and we've got to make sure there is that genuine choice and contest, it is a good thing if overall you're building a national consensus towards the same overall direction.
So would you say this is the right balance between recovery and reform?
Yeah, I think so. I think we are seeing some signs of the NHS's recovery, and we are seeing radicalism from the government in terms of reform, and we are seeing that welcomed across the party political divide. I think that is a good thing. We will continue to work in this spirit, and I've been kind of delighted informally as well as formally to bring in people who might not kind of share our party colours, but care about the NHS and want to help this government. And, in that spirit, I was delighted, for example, to have on the department's board Camilla Cavendish, who, she worked for the last Conservative government, or not, I don't want to say literally the last Conservative government, there's so many of them, but a Conservative government over the last 14 years. But she's got great ideas on social care. She's a committed public servant. Why wouldn't we try and bring in people with that level of commitment, skills and experience? We won't always agree on everything across the party political divide, but against the backdrop of very fractious politics, I think it is a good thing to remind the public that we have more in common than the things that divide us.
Thank you.